we're going to look at point-of-care ultrasound for lower extremity venous thrombosis. So you have taken a number of different lectures leading up to this. Hopefully all of that background information will make this really a simple process to learn and understand. So we'll get right to it. The objectives today, we're going to have you identify the sensitivity and specificity of Pocus lower extremity venous, or LEV. We're going to have you differentiate a traditional sonographic lower extremity venous from the point-of-care lower extremity venous. Describe the venous anatomy included in the Pocus LEV and its ultrasound appearance, as well as define the differences between a continuous compression Pocus approach and a 3-point exam. And finally, we'll have you name the limitations and the benefits of the Pocus LEV. So indications for lower extremity venous, as you know, is going to really have a high clinical evaluation significance. So some of the things that are going to lead you down the road to do a lower extremity LEV would be a patient that meets one of the criteria of Virchow's triad. So stasis, trauma, hypercoagulability. Any of those three things can put a patient at higher risk of thrombosis and therefore would be a very important part of the clinical history of the patient when determining whether to move forward with this exam. A patient that's also demonstrating dyspnea would be at high risk for an LEV because most of our pulmonary emboli come from an embolism from a clot in the leg. Swelling of the leg, redness of the leg, heat of the leg, all of those three things are going to have major indicators of a DVT. And then a positive D-dimer blood test can be considered an indicator. Another thing that you can utilize is Wells criteria. That's another set of criteria that can help you determine whether it's prudent to move forward with a DVT test or not. Now, the D-dimer is relatively non-specific for a DVT, but a lot of practitioners still utilize that in determining whether to move forward with the exam. So, considerations of a lower extremity DVT exam. 50% of patients with a known PE have a DVT that was basically the origin of the pulmonary embolism. 40 to 50% of patients with a DVT have a concurrent PE. So you can have that DVT that never turns into a PE, but it does put you at much higher risk of that compromising pathology. Thorough exams of all major veins can be completed in an imaging department, but most of the time when we're focusing on a point-of-care ultrasound, we're looking at the areas that are going to have the highest rate of findings. So we can do that and do a very focused Pocus DVT exam, keep it very brief, and even with those focused exams, they found that studies indicate that they have a high sensitivity of about 96% with a specificity of about 97%. Well, the caveat to this is that it has to be somebody completing the exam that is comfortable, knowledgeable, and has a high level of skill. So if you look at the differences between the traditional exam and the Pocus exam, one of the things that's really going to stand out is where they can both be very sensitive and very, very specific. The traditional exam is much more thorough. So with the traditional exam, they do a triplex exam, meaning that you evaluate the entire length of the deep vessels in B mode, or black and white imaging, in transverse and long. And then they come back and they do it with color, and then again with spectral Doppler. So it's a very much more intense study. So therefore it should be a little bit more sensitive and specific. Again, just like with the point of care DVT study, it is going to be highly dependent on the skill of the sonographer completing the exam. With the traditional exam, they complete compression of the entire lower extremity venous system, basically hip to ankle. So they're going to work their way all the way down to that ankle, looking at the calf vessels as well. Now, with the Pocus exam, that is not going to be as extensive. As I mentioned, the traditional is a true triplex exam, meaning they use color, spectral, and B mode, and it can take quite a bit more time than your Pocus exam. So some of the benefits of the Pocus is that you can do it quickly. You can do it by the bed. And still have a high rate of sensitivity and specificity. But the Pocus exam really, if you're doing it in its most simplest form, is really going to focus just on the B mode or the black and white imaging. It's going to leave out the color. It's going to leave out the spectral that can provide additional information. And yet, again, the outcomes from this are pretty good when completed by a skilled practitioner. So just a really quick review of the anatomy that's going to be essential as you're working your way through one of these studies. So we know that, lots of times when we're teaching the arterial system, we're talking about it bifurcating. It starts at the heart and it bifurcates into these different arteries as it goes down the leg. Well, when we're talking about a venous system, we really are talking about anastomosis. So we have these veins coming together, anastomosing together, creating new and larger veins. So we're going to talk, we can look at a couple different ways. We could look at it from the foot up. We could look at it from the top down. But because we typically scan from the top down, I'm going to go ahead and discuss it in that respect. So we have our IVC that is in our abdominal cavity, of course. And then that is going to bifurcate into, it's going to be actually, its origin is going to be from anastomosis of the common iliac left and right common iliac veins. Those common iliac veins are created by the external and internal iliac veins coming together. And that external iliac vein, which is what kind of leads us to the leg, is going to occur at the anastomosis of our greater saphenous vein, as well as our superficial femoral vein and our deep femoral vein. And as those all come together and reach the inguinal canal, that small area there is called our common femoral vein. Now, the deep femoral vein, also known as the profunda, it dives very deep and is considered relatively low risk for a DVT. And so while we look at it in its most proximal region here, we really don't follow it into the leg in any depth. The vein that we really continue to focus on is going to be the superficial femoral, or some practitioners will just refer to it as the femoral. So the femoral vein is going to be found going down the medial thigh all the way until it dives through the adductor canal. This is going to occur at the medial leg about 4 inches above the knee. Once it does this, your ability to follow that vein from the medial thigh gets very challenging. So most of the time, we will pop behind the knee, find the popliteal, and then follow it back up through that canal until we're sure we've seen all of that vein. So as it dives through that adductor canal and moves to the posterior knee, we then refer to it as the popliteal vein. Now, the popliteal vein originates from the confluence, or the anastomosis, of the anterior tibial vein and the tibio-peroneal trunk. So here we have the anterior tibial, here we have the tibio-peroneal trunk, and the tibio-peroneal trunk was formed from the posterior tibial vein, which goes right at the medial ankle, and the peroneal vein that goes right down the posterior aspect of the muscular area of the calf. So for quick review, if we want to look at it going the other direction, we start out with our posterior tibial and our peroneal. They're going to come together, anastomose, and create the tibio-peroneal trunk right here. Once the tibio-peroneal trunk comes in and adds itself to that tibio-peroneal trunk, then we're going to have our popliteal. Popliteal is going to continue posterior to the knee until it moves anteriorly and through the adductor canal to the medial thigh. Once it's past that adductor canal, then we refer to it as the superficial femoral, or sometimes the femoral vein. It is going to go way up until it almost reaches the patient's groin area. At that point, it is going to anastomose with the deep femoral, or also known as the profunda. And then just slightly, just centimeters above that, we're going to see the greater saphenous vein dump in, and that's where we have the origin of the common femoral. Common femoral is going to ascend through that inguinal canal And as it passes the inguinal canal, then we refer to it as the external iliac. Once that internal iliac joins the external iliac, and then we refer to it as the common iliac, the two common iliacs come together and they create the IVC. Okay, so now that we looked at the veins on a diagram, we're going to kind of apply that to ultrasound imaging. So the common femoral was originated when the superficial femoral and the deep femoral or profunda came together. So right here we see the common femoral. It's side by side with the common femoral artery. And then here is where the greater saphenous vein comes in. Now, it's important to note that the greater saphenous vein is technically a superficial vein, so it's not really of concern theoretically with our deep venous study. However, we do like to take a really good look at this particular area because if we had a clot in the greater saphenous vein, it would be very easy for that clot to extend into the common femoral. So while we, especially in Pocus ultrasound, we don't typically pay a lot of attention to our superficial system, this particular junction is going to be of interest to us. So here's our common femoral, here's our greater saphenous. You're going to evaluate that without and then with compression to make sure that that is clear of any sort of thrombus. If we turn on the area and slide just a little bit superficial, you can see here's the common femoral. That was, again, the result of the anastomosis between the superficial and the deep femoral. And then here we see the greater saphenous coming in. In this long view, you can see that there is actually a very loose clot in this region. So this would be at high risk of embolization because you see how it is free flowing from the wall. So with this, you'd have your answer right there, right at the first few images. But if you wanted to progress and find whether there was any additional clot or how far down this clot went, then you're going to follow down and you can identify at the superficial and deep profunda or deep femoral or profunda area where you can see the separation of those two vessels, and you can compress them, making sure that they both are compressible. That same area right here we see our superficial and our deep. So this image over here on our left, it is really going to relate to this region where our greater saphenous comes in and joins with our common femoral. Just a little bit lower than that is where these two images come from. So this is our superficial femoral and our deep femoral coming together, anastomosing to create the common femoral. So superficial, deep, anastomosis, common femoral. Now here, if you go ahead and you continue on down, let's say that you follow the superficial femoral all the way down. You followed it as it transversed through the adductor canal. Here you would see posterior knee, you would see something like this, where the popliteal artery is going to be deep to the popliteal vein, and this is generally one of the easier areas to compress. Now, as we look at that popliteal vein in long, it should look a little bit something like this. Make sure that you're not popping between the artery and the vein, as that can get confusing. But remember that the artery is going to be pulsatile, the vein should be phasic, and so that should demonstrate the difference if you're a little bit unsure. Now here is the popliteal vein, where we actually see that anterior tibial vein dropping in. If we were to look at it a little bit higher, here you can see basically the anastomose just distal to the popliteal. So we have our popliteal arteries our posterior tibial and our profunda coming together, creating the tibial-perineal trunk. Then once the anterior tibial dumps in, then it's going to create our popliteal, and so here's our popliteal and transverse. Now, if you happen to be, very, very thorough, and you want to take a look towards the ankle, what you would see is a set of posterior tibial veins, so vein, artery, vein, and then deep to that would be your perineal veins, vein, artery, vein. In transverse, those would have to all compress except for the arteries, of course. And then if you lengthen them out, you'll see them join together, the perineal and the posterior tibial. like we see here. And then once that anterior tibial is added in, then you can call it the popliteal. So what images, what are you going to do for this point of care ultrasound exam? So first of all, you want to select a transducer. We usually utilize a high frequency 8 to 12 megahertz linear a linear transducer for the venous studies. Now, if a patient has extensive edema or swelling, or maybe they're morbidly obese and you're having trouble getting a clear image of that vein, then it is 100% okay to utilize maybe a curvilinear or a much lower frequency transducer, whatever gets you the penetration you need. But for most people, we like the good visibility that we get with that higher frequency transducer. Some key points to remember while you're scanning. Arteries and veins are going to be right next to each other in your lower extremity venous. And so some of the things that you can utilize to remember or determine whether something is an artery or a vein. Remember that the arteries have that more thickened tunica media, and so they're going to be more rounder in nature and more consistent in size. They also should not compress. If you're able to compress an artery, you're pushing way too hard, which usually isn't the problem. Most of us struggle with pushing hard enough. If you're really uncertain whether you're on an artery or vein, it's very simple. You just put color flow on the vessel, and then you look and see, is it pulsatile, and do you have any phasicity? If it's pulsatile, it's an artery, of course. So the veins, in comparison, they're going to be more oval. They're going to vary more in size. They're going to be compressible as long as they're not containing a clot. If you're still unsure if it's a vein, you can again use color and spectral flow, and you're going to see more of that phasic motion of blood than you do with an artery. Another really important point is that you should never ever try to do your compressions in long. Odds are you're just going to roll off the vessel. You're going to think that you've compressed it, and yet you'll just be missing the vessel completely. The only accurate way you can do compressions to see if there's thrombus keeping that vein open is to do it in transverse. Most areas that we're looking at for a clot, especially in traditional lower extremity venuses, we're going to be compressing about every centimeter to 2 centimeters. If you position your patient supine, you want their head a little bit elevated. That will help increase the flow or increase the pressure within the legs, which will cause the veins to dilate a little bit, so that head elevation can be very useful. Then you're going to want to have the patient bend their knee very slightly and then externally rotate their leg outward so that you have access to the medial thigh. When you're ready to start the exam, you're going to begin the scan right about the inguinal ligament. Now, there are some circumstances where you may want to follow up into the pelvis and look at the common iliac or the external iliac, but those can be a lot more difficult to assess. You'll definitely, if you choose to do that, you're going to need to use a lower frequency curvilinear transducer, and you're going to have to add color and spectral flow to your scan. So for the basic point of care LAV, we're going to begin in transverse at that inguinal ligament, and we're going to try to identify the external iliac. Once you've found that external iliac, once it's past the inguinal ligament, you're going to start your compressions. You'll complete compressions every 1 to 2 centimeters from the inguinal ligament through the distal popliteal area. You're going to compare the vein with and without compression at each compression point. So whether you choose, and we'll talk about 2 different options here, whether you choose to do 1 to 2 centimeter compressions all the way down from inguinal area to popliteal, or you have the option of looking at just those anastomosis sites. Whichever course of action you choose to take, you're going to be comparing how well the vein is compressing compared to the vein with no compression. So, during the more thorough exam protocol, you're going to carefully assess an image at each of the following levels. So you're going to start at that common femoral vein with compression. You're going to identify the greater saphenous vein anastomosing with the common femoral, assess that area with compression. Then you're going to follow it down, and you're going to continue compressions every 1 to 2 centimeters until you reach the anastomosis of the superficial and deep femoral veins, and you're going to image at that area. Now, this is where you can take one of two options. Probably the most thorough option would be to continue to compress that superficial femoral vein all the way down to the popliteal every centimeter or 2. If you're looking for a very brief study, you can then jump just to the popliteal, and you would then image the popliteal just distal to the adductor canal. You're going to compress the image the popliteal vein posterior to the knee, and then continue to follow and compress that popliteal until it reached the tibioperoneal trunk. Now, while a traditional exam would go beyond that into the calf, most point-of-care ultrasound is ended at that region, because the idea that those veins in the calf are relatively small and unlikely to throw a major thrombus that would have a significant impact as a PE. So really quick review here. You're going to start up at the area of interest near the common femoral. So you'll start up here. You're going to compress until you get to the greater saphenous junction. You're going to compress and image at that area. You're going to continue to compress until you see the anastomosis of the deep and superficial femoral area. You're going to image at that region. Let's say you want to be thorough. You're going to continue to compress every 1 to 2 centimeters all the way down that medial thigh until you lose the vein. Then you're going to basically pop behind the patient's knee, angle upward, and compress from behind the patient's knee all the way through the popliteal, and then image there at the popliteal. Continue compressions every centimeter or so beyond that until you see the origin of the tibioperoneal trunk, and at that point you're going to have a completed exam. So that very simple, very quick process that really has a pretty good feedback. So as I mentioned, that is going to be the more thorough exam that I just described, where you're doing those every centimeter to 2 centimeter compressions. You do have the option to do a 3-point Pocus vascular exam, where basically you take your transducer, you very quickly compress and image the veins at the common femoral vein, greater saphenous vein anastomosis, at the superficial femoral vein and deep femoral vein or profunda anastomosis, and in the popliteal region. So with basically 3 images, you are getting a really quick assessment to help you determine the risk factor of that patient with for DVT. So again, you know, you're going to be as confident in the exam as you're confident in your pictures, and as thorough as you are in your images. So with this, it might work really, really well to make those really instantaneous decisions with being a little bit more thorough and compressing that the greater superficial femoral all the way down. That might give you a little higher level of confidence. So again, just 2 different approaches. So what are we expecting from these thrombi? So thrombus findings, they're going to be most common at valves or areas of anastomosis, and that's why practitioners can get away with doing that 3 image evaluation. They're really looking at the highest rate of feedback that they're going to get by evaluating those anastomosis areas. If there happens to be a thrombus present, you're going to find that that vein is not fully compressible. If you're compressing enough to distort the artery at all and the vein is not compressing, then it's highly likely that there is a thrombus there. If you can't see it by adjusting your 2D gain, sometimes you can bring it into view. Now, thrombus, like we talked about in previous lectures, is going to be various in appearance based on the age of the thrombus. So you're never going to be able to look for one classic symbol of a thrombus. It's going to be all within context of how long that thrombus has been there. So pretty easy exam. We can certainly help you with this when we come out to do your scanning days. Hopefully you'll find this useful, and we'll go ahead and go to our summary. So our summary point-of-care ultrasound LEVs have a high sensitivity for DVT. They can be done very quickly, especially if you do the 3-point evaluation, while still maintaining pretty good quality. They're obviously not as thorough as a standard sonographic LAV exam, but sometimes they can help a practitioner decide if that's somewhere they want to go with that patient or not. It interrogates the vein from the inguinal ligament to just beyond the popliteal region, and it can utilize a continuous compression approach or a 3-point exam to accomplish the required outcomes. Again, you're going to only be limited by the skill of the practitioner and the extent of the exam. So hopefully this gets you excited to go and take a look at somebody's leg, especially if you feel like they're at high risk of a thrombus. And we will see you next week.